Good afternoon and welcome to another Concord and Victory interview. Today we're joined by a renowned psychiatrist, Dr. Jeremy Broadhead. So Jeremy, do you mind telling us a bit more about yourself and your journey as a psychiatrist?
And my journey to psychiatry, presumably.
Yes, please.
I didn't start out when I was at Stowe thinking I'd like to be a psychiatrist. I thought I'd like to be a doctor. And so took all the requisite steps to get to medical school. And I don't think actually most people really know what specialty of medicine they want to pursue in those early stages. You can rule some out straight away when you do your first bits of training, and some will become very appealing. So initially I thought I'd like to be a surgeon. And then there are various things about training as a surgeon which are quite off-putting, I think, which is that you have to be willing to get out of bed at 2 in the morning to do emergency operations and things until you're about 40 years old. And then oncology appealed. So I did both those things. And then I went into neurology. But there's a part of the medical history you take when you're training. You go through all the symptoms, the physical symptoms someone has, and you know the specific symptoms you're going to ask about people's cardiovascular systems and their chests and their abdomens and their urinary systems, etc., etc. And then you take something called the social history, which is what they do, whether they're married, whether they have children, what makes them tick as individuals. And it began to dawn on me that that was the bit I found by far the most interesting. And then when you couple that with actually trying to understand this wonderful organ that sits in our head, then that's when you decide I'll do psychiatry. So I did my psychiatry training, which is long, but it's the same as any other specialty. And I've done a lot of interesting things along the way, which I won't tell you now, but you might want to come back to. So that's the overview.
Thank you. So you talked about, specializing in psychiatry, but before that, how did you find medical school and what was it like to actually, get into? Was it difficult? How was it?
I don't think medical schools are the easiest things to get into. I did the first half at Oxford and then the second half at one of the London teaching hospitals, which is what you used to do if you went to Oxford or Cambridge, because they didn't have associated hospitals that took enough people. So that was fine. It sort of cleaves your training very much into two halves. The Oxbridge part is you're the same really as any other undergraduate. So you meet a broad array of people rather than just being with medical students, which I think is a good way to do it. A lot of people in their training will do an intercalated degree, which is usually a research degree, which if you want to sort of polish your CV on the way to doing a specialty is a good thing. I may be a bit out of date now because, as you can tell, I'm quite older, but it's probably the same. Things don't move that much. So you do, it's hard work, but no harder work than law or anything else.
Okay, thank you. And then to specialize in psychiatry, how was that journey? Like, how was it?
Well, broadly, you want to get onto, so if you qualify as a doctor, you then have to do at least 2 years of general medicine and sort of general surgical topics so that you're broadly trained. Once you've done those, you become a registered doctor with the General Medical Council, and you can then choose which specialty you want, and you want to get onto a training rotation. And some rotations have much more kudos and prestige than others, so you decide how ambitious you're going to decide to be and trying to get onto one of the training rotations that you want. When you're in that, you work as a doctor. as well as doing the training that that rotation might offer. And it paves the way to taking, in the end, 2 sets of exams for the Royal College of Psychiatrists. They're quite testing. The first ones are all sort of multiple choice things and just facts you have to know. The second is all about how you interview patients and how you interact with patients. And of course, that's a skill that you're honing all the time, in that you have a patient in front of you who may not want to tell you very much at all, or want to keep it very much under their hat that actually they're in a terrible marriage and that's why they feel awful. And you have to, through asking the right questions in the right way and not phasing people out, you have to sort of be able to get into their minds and lives, which is always extraordinarily interesting. You know, in general medicine, you just get to learn that every stomach's the same, every gallbladder's the same, every heart's the same. But in psychiatry, no 2 people are the same. It's like living through a lot of series of The Archers, or I don't know if you know The Archers, but it's a soap opera on the radio. It's been going for a long time. But you're hearing people's stories unravel and how their lives are. And in the end, most of the pain in the world is mental. So if you're interested in improving the lot of humanity, it's a good way to do it. So once you've got your Royal College exams, then you do a little bit more as an apprentice, basically, before you apply for a consultant job. But that all takes a long time. But you can break it off and do things. So in the middle of mine, I got a job as a psychiatrist in Africa, in Zimbabwe, for 2.5 years, which is a remarkable experience, because you can go on holiday to exotic places, but you never really know what the person driving the taxi is thinking, or how these people's lives are, or what they believe. But if you are doing psychiatry in these situations, you really have license to explore anything you think is pertinent. So that's just an example of how you can sort of intercalate things in your training. That's a very long answer, isn't it, to your question? Am I wrong?
No, it's good. Thank you. It's really good. So you spoke about being a psychiatrist in Zimbabwe, and I also read you practice psychiatry in America and New Zealand. Is that correct?
Yeah, I can't keep.
Is psychiatry different in those places compared to like the UK? And how was your overall experiences in each of those places as a psychiatrist?
That's a good question. So when I went to Zimbabwe, there was a strongly held view that believing people in sub-Saharan Africa had the same mental health conditions as they do in the UK was just another phase of colonialism and was very rejected. But when you work in one of those countries, you realize that the people sitting in front of you have exactly the same presentations of the same psychiatric disorders. And having worked in Africa and several places now, and the South Pacific in America and London, you know that the diagnostic manuals that have developed in the West map onto humanity wherever it lives. What is different is the content. So we talk about the form of things and the content of things. So you might have a very depressed mental state, and you'll tend to think in terms of not being worthy, or having failed, loss of confidence, let people down. That would be the content. So the content in Africa might be very different. It might be feeling very low, but feeling that there's another sort of culturally appropriate reason for that. In another example, people with schizophrenia develop hallucinations, which are voices which occur outside their head in external reality, which they believe are real. And these voices say things to them. And when I was training, most commonly, those voices were connected in some way with the IRA. The IRA was part of the big sort of news headlines of what was going on in Northern Ireland at the time. I suspect now, if you work with schizophrenia, it'll be much more to do with Donald Trump and Putin, or whatever the current affairs of the day are. So the contents change, but the form is the same. But you get good at exploring the form and then divining the content and working out how to work with it. So your question was how different these things work. Well, I think it's the systems within which health care and mental health care is delivered, which was different. So in London, you all know, we've got the NHS, which is wasn't so overwhelmed 30 or so years ago as it is now. There seems to have been a huge increase in mental health problems, a huge increase in the recognition of neurodevelopmental disorders. So that includes dyslexia, ADHD, autistic spectrum disorders. So everything's getting very overwhelmed. In America, the systems are not what I would have wanted to work in, really. I was there as a research fellow, but it was in a hospital called Johns Hopkins, which is in Baltimore. And it's full of very well-insured or wealthy people. And then for the local population, there's an emergency clinic, which is run by the most junior doctors who don't know anything. So you can see this very much the two-tier system there. New Zealand is a bit like the NHS, but it was trying to model a whole bicultural approach. So instead of being sort of multicultural under one umbrella, they had parallel services for Maori people and for the rest of the population, but it was doubling the cost of the health care delivery, so that didn't survive. So you can go anywhere and practice psychiatry, and you'll see pretty much the same things, but it's terribly interesting to see how the contents vary in these different settings.
Thank you. You also spoke about the NHS being different now. Would you say psychiatry has changed over the years, and how patients,
Well, I think there are sort of two elements to what you're saying. One is sort of mental health care delivery within the NHS. I can talk a bit about that, but the other thing is that psychiatry is a very rapidly evolving medical specialty. So 30 years ago, you couldn't look at people's brains unless you took them out or filled the ventricles, which are the holes in the middle of the brain, with air, and then you could get some idea of what was going on. But of course, now with MRI scanning and PET scanning and high-resolution CT scanning, you can see right down to tiny little strokes or bits of brain that have very particular functions. And it's allowed the amount of knowledge that we understand about any illness just to increase exponentially. And we're much wiser about it all. 30 years ago, you were looking at the difference between different conditions really by whether there were slightly different symptoms, and all the research was about that. Now it's much more biological, which is good. And there are much better drugs. There are fantastic drugs now without side effects, and you don't see people looking like those in One Flew Over the Cuckoo's Nest, if you've seen that film. And there are treatments that have stood the test of time, one of which tends to shock people, which is ECT, which is electroconvulsive therapy. I don't know if you've heard of that. So you basically put an electric shock across people's heads and they have a seizure. And in the past, they wouldn't have had an anesthetic and they wouldn't have had a muscle relaxant. So they were having a full seizure, which the poet Sylvia Plath describes in her Bell Jar and other poems that she wrote. That book, that's a book, and her poems. But that was all fairly horrific. But nowadays, when it's given, people have a full anesthetic for about 3 minutes and then a muscle relaxant. So you don't see people having a seizure. But it remains an extraordinarily effective treatment. So and I suppose I use it about once a year, but I just tell you about the last person that I gave it to. But she was youngish, I gave mid-40s, bit younger actually, late 30s. She had 2 children, an 11-year-old and a 13-year-old, a very good husband. And she developed a very, very profound depression. When people are profoundly depressed, they're not just saying, I'm sad, but I'm still going to play tennis or whatever. They're absolutely incapacitated. And she hadn't been out of bed for a year. She wasn't eating. She wasn't washing or looking after herself. She couldn't look after the children. So her husband had to give up his job, which was in the city, to look after her. So you can see the whole family beginning to fall apart. And we tried drug after drug and combinations of drugs, and none of them made any difference. And no psychologist could get through to shifting this. So I thought, well, we need to try electroconvulsive therapy. And within a week, she was better. So it's a dramatic and good treatment. And she's happy to talk to anyone about how it altered her life for the good. But one hears so much bad said about it. And people who need it aren't getting it because it's all getting so stigmatized. But that's a bit of a red herring, but I thought it might be interesting in terms of the range of treatments, from talking treatments to simple drug therapies to drugs which are more complicated to use and in combination. Occupational therapy, psychology will work together with psychiatry. And then you've got the more dramatic treatments like ECT at the other end. But most people you can make a big difference to. So you feel effective, which is nice for doctors to feel.
Would you say that's the most rewarding part of your job, helping people, making them feel better?
I think if you're not interested in making people feel better and improving their lives, then you probably shouldn't be a doctor, but you shouldn't be a psychiatrist. Actually, that's not quite right, because you could do medicine and then become a pathologist or a microbiologist, something very biological, but definitely you're not suited to psychiatry. And the interest of psychiatry will come to you if you're interested in people and their lives and how things affect their lives and their capacities and indeed their families. And the reward comes from getting your formulation of things correct, so that between you and your clinical colleagues, the psychologist mainly, and perhaps your clinical pharmacist, you can make a huge difference to people.
That's really nice. You spoke about how psychiatry is always evolving. So with the emerge of AI, do you think that would massively impact treatments in psychiatry, or do you think no?
Well, I'm going to begin at a very mundane level, but something that happens in medicine generally is that everyone who sees them writes a lot of notes. And in the old days, that used to all be in a paper file. And if a patient came into the room and you hadn't seen them before, you could flick through the file pretty quickly. So at the front, there'd be the handwritten notes. At the back, there'd be all the letters to the GP. So you could get up to speed very rapidly. That's all gone. So what you do now is tap into the patient on your computer and you find 120 PDFs of letters and notes, and they're all badly labeled because the person who's labeled them doesn't really know what to label them. And you actually haven't time to open them all. So people end up asking their patients about themselves, which isn't really establishing much confidence in you, in the doctor, if you clearly don't know anything about the person sitting in front of you. So there's AI now where you can put the 130 letters, press the summarize button, and within a minute, that's all been sorted chronologically. And then beautifully, the patient may say, I'm sure I've had that drug before, but I don't remember the dose. And you just say, well, we'll ask the health narrator here, and you put it in and it tells you. So it's a wonderful tool that you can use with your patient. psychiatry is a highly collaborative subject. You don't do things to people. You can't force people to think differently or lead their lives differently. You work with people to change things. As a surgeon, you can be much more directive. So that's AI at one level. And I guess, I don't know, but it'll enable research questions to be put, which one might not have been able to think of before. The other thing is that in academic psychiatry, there are a lot of literature reviews. So you might decide you're interested in panic disorder in people who are 30 years old. And then you go through to the library and you look up all these papers and read them and summarize all. You can do that pretty instantly with ChatGPT.
Thank you. One last question.
Yeah.
Has working in psychiatry as a psychiatrist perhaps changed the way you view humanity and the way you understand others?
Yes, I think it does. I think it does, because inevitably you have got to know thousands of people at great depth, from Wormwood Scrubs high security end to people in Downing Street. You know, you've seen the whole range of humanity in different ways and got to know what makes them tick. Now, most people don't have that opportunity. The people they know are their friends and their family, and the rest you sort of rub along within the sort of etiquettes of society, but you're not really getting to understand what makes people understand, what makes people who they are. So I think you get a sort of a deeply honed professional intuition about people. And I think I can't think where else you really get that to the same degree, because obviously your training is about understanding people and knowing how to ask questions to achieve that. So it's very rewarding, I can say, at this end of my career.
Thank you so much. Thank you.
It's a pleasure. It's a pleasure.
Questions?
Questions? Anyone have questions?
I've got a quick question, Jeremy. Thank you. You mentioned mental health crisis and the NHS. We read about extensive waiting times to be seen by patients. And more recently, we're now reading about cutbacks from the new government. What's the solution to the mental health crisis in the UK? If you had one magic, not magic pill, but one magic thing you could do, what do you think you would do and how would it help?
I would arrange mental health services in the way they were 30 years ago. So what happened was that basically the country was divided up into patches of about 30,000 people. And a psychiatrist with his team would be responsible for looking after the mentally ill people in that population. So the people with more serious illnesses like schizophrenia or bipolar disorders or severe anorexia nervosa would be directly under the team. People with less severe, the team would help the GP. But it was all very cooperative, and you also got to know who all the high-risk people were in your population. But then a decision was made at the highest levels of government by people who've probably never seen a patient, that we shouldn't do that, and we should have different teams for different phases of people's mental health. So you might have looked after them for a very long time on a sort of continuing care basis, but as soon as they became ill, you transfer them to another team which deals with the acutely ill people. And when they can't look after that person in the community, they move to a consultant who looks after people who are in hospital. And when they move out of hospital, they move to another team who looks after people who are recently discharged from hospital. Now, what that involves is a huge amount of time transferring information between all those teams, which is a waste of time. also the information gets skewed. It's like Chinese whispers. And when I went from London, which did the sort of patch model of 30,000, to New Zealand, they were already operating this multiple team system. And I could see how inefficient it was. And because New Zealand has a population which is rather smaller than ours, at about 4 million, and they recognized this wasn't a good model, they moved back to the 30,000 patch model very quickly. But we haven't. We've stuck with this very segregated system, and it wastes a lot of clinician time, and people can't work well together. I think that and the note summary thing I described to you would make a big difference in terms of how many patients could be seen, which is the bottom line.
Thank you.
Next question.
Hi, what skills would you say are like the most essential for a successful career in psychiatry?
Well, they're very personal skills. I think you have to be very patient. It's no good if someone's struggling to tell you their inner thoughts and you get cross with them. You've got to be able to sit and be with someone trying to articulate very difficult things. So you have to be patient. I think you've got to be an inherently kind person. Otherwise, that's not going to work very well. You've got to know your stuff. And it's quite a complex subject, which is a way you don't discuss overtly with the patient, but there are a set of tools you have behind the screen which you can pull out for people. So you've got to be clever and able to use those things. But you might be patient, kind, and clever, but you may have just no interest in people or making them better, in which case that wouldn't really work very well. So you've really got to have all those things. I think that those would be the main points, really.
So you sort of spoke about how your journey as a psychiatrist has changed your or sort of developed your perspective on humanity, but has it developed your perspective on personally yourself or your interactions with family and friends as well? How has that sort of changed or developed your perspective in your personal life?
Well, I don't think any of those things have deteriorated. I think it only helps to be wiser about people and human problems. But I think that it's an important point to make is that people in the general public tend to think that if you're a psychiatrist, you're analyzing people all the time. Psychiatrists don't analyze. That's psychoanalysts, who are a very different beast. They're not medical, but they've usually trained for a long time in a school of psychoanalysis, like Freudian analysis, Adlerian analysis, Kleinian, Jungian. And I think they're more likely to analyze people that they're interacting with as they go along. I think psychiatrists are pretty normal on the whole. I'd like to think.
So what are the challenges you face in a career in psychiatry?
Challenges. You have a lot of responsibility. It depends where you're working. If stories are good. Stories are what psychiatrists are about. So I had my first consultant job, and this man came to see me and said that he was very upset because his wife had left him with his two children, their two children, who were 9 and 11. And he wanted some help. Now, what you do as a psychiatrist when you have someone like that is try to work out what's wrong with them. And is this person seriously disturbed in an affective sense? That means in their mood or anxiety. Are they psychotic? Do they believe something which doesn't really exist? Or are they just a person struggling with a bad life situation? And my view was the last. but he started talking a bit worryingly, and I got a second opinion, and then thought, I'm not clear about this. I need to make him come into hospital against his will, which involves using the Mental Health Act. And you need 2 doctors' recommendations and a social worker. And we did that, and the social worker said, there's nothing wrong with this man. I'm not sanctioning him going into hospital. And a week later, he took those 2 children into his flat, got a butane gas canister, turned it on, and blew all of them up. So you're going to have things like that happen in your career, and you've got to be able to cope with it. If you've done the right things, then you've done the right things. And I'm afraid terrible things do happen at times, but we couldn't have done anything different, I think, unless the social worker had said, okay, well, I've got 2 doctors who think this isn't quite clear. I do need to get them to come into hospital. So that's a pretty hideous thing, but any psychiatrist will have a story like that. Similarly, there's a sort of maxim within psychiatry that if you don't have one patient who kills themselves each year, you're seeing the wrong people, because you should be seeing the most severely ill, not the people who are gently depressed. So you will have patients who end their lives, and you can't keep everyone alive, however hard you try. If people are determined, it'll happen. So those are real sort of personal tests. And if you think you crumble under those situations, then that's not a great thing. But anywhere in medicine, you're going to have people who die. They'll just die in different ways. But psychiatrists tend to be held a bit more responsible for suicides than a surgeon is for someone dying on the operating theatre table. Otherwise, I think those would be the main challenges. And then there are always the issues of working with different teams in different structures and so forth. But that's the same whatever you do, whether you're an accountant, lawyer, doctor.
Hey, sir, thank you for your time. Let's say hypothetically that one doesn't get the grades to do like a psychology degree straight away in university. Is there like any other way to become a psychologist? Was any loopholes or such?
So this is psychology, not
Yeah.
psychiatry. Yeah. So there's a sort of set of people who do talking treatments. So they don't do the sort of interviews psychiatrists do to make diagnostic appraisals of things, and they don't use drugs, and they can't use any other treatments. And they just use psychotherapeutic means of working. And there are quite a number of tiers of those. I'd say that the most difficult and highly trained are the clinical psychologists. So on the whole, they've had to go to university, do a psychology degree. If they then want to be a clinical psychologist, they have to have done very well in that degree and then get onto a clinical training program. And they train for almost as long as a doctor does. And they're wonderful people to work with. There are then people who decide, for example, you might have heard of the term CBT. Have you heard of that? Cognitive behavioral therapy. It's a very commonly used therapy. But you can learn to do that on its own in not that long and call yourself a cognitive behavioral therapist. And then you would see patients who the psychiatrist usually would think just need CBT. So you'd be a cognitive behavioral therapist, and there are other sorts of specific therapy. And those would be easier to get into than getting into read psychology. Ideally, you'd have a degree. And then there are people who are counselors, who've done counselor trainings. And I don't know that they need anything particularly. It's probably more to do with their character traits than their academic training. And then there's a whole lot of people who do weird and wonderful things that no one's ever proven to work. But some people like being a hypnotherapist and things like that. So to whoever I'm speaking to, because I can't see any of you, don't aim for the hypnotherapy. I think if you don't think you can get in to do a psychology degree, then just do a degree that interests you and think of becoming a psychotherapist. There's a huge demand for psychotherapists. You'll always have a job. I never go without food.
Thank you. Thank you so much. Thank you.
We are done.